Greetings from ILBS, and I really thank you for joining this interactive session. I have no conflict of interest except we have very bright faculty and brighter residents, which put us at second position after AIMS Delhi. I will have brief interaction on different parts because most of it was covered as far as HPV infection virology last time. I'll give you some more insight into the virus. It's a DNA virus. It's an incomplete virus. One strand is full. The other strand of this DNA is incomplete. Whenever we have a virus detected in the blood, we are detecting surface antigen, which is a protein. Then we have an envelope antigen, which is E antigen. The inside of this is the core antigen. Now this core antigen never comes out into the blood. Why? Because it lacks 3 amino acids which are present in the E antigen. So once you have core antigen plus 3 amino acid, it becomes soluble and it can cross. What does it mean? If you have E antigen positive, it means core antigen is always there. The next important part is the DNA. The DNA in this is normally like this. But whenever there is a replication and others, you lose this polymerase and it becomes a closed, covalently closed circular DNA. So whenever we have a person, the cell must die, otherwise this DNA cannot come out. Now this is a hepatocyte. Now let's go further. Now here it is a hepatocyte. This is your blood. From the blood in the liver, in the sinusoids, this virus gets into the liver cell. In the liver cell, you have a receptor, bile acid receptor, by which the virus comes inside. This is the nucleus of hepatocyte. In the nucleus, you have one, as I told you, by losing the polymerase, you become covalently closed circular DNA. Nothing can break it unless the cell dies. Other than that, you will have the virus. The virus can make a integration into the host. मतलब host में जिसके अंदर ये है virus integrate. This integration can lead to cancer, even if the viral levels are low. The second part is by losing polymerase, it becomes a closed DNA. Now this will multiply. Now once it multiplies, it can give you surface antigen alone. It can give you core antigen alone. It can give you an RNA, polymerase, all these. To cut the story short, the person can release HBsAg directly without DNA. Or there can be all particles assembled together to make a DNA, single-stranded, not double, single-stranded DNA. Now this DNA is converted from an RNA. So initially it is hepatitis B RNA. It converts into DNA. All our drugs today, tenofovir and entecavir, work here, while interferon works here and here. Now this single strand DNA becomes double strand, full virus, and it comes out. So one more time, I'm trying to ensure that you know the life cycle of the virus. So when you are testing hepatitis B surface antigen, you are hollow particles without. You're also having surface antigen with a DNA inside, and several times you may have other types of truncated virus in this. So HBsAg, 9,999 particles are hollow when one DNA containing virus is formed. I hope you understand this. So what will happen when the body's T lymphocytes come? They think this is the virus. However, this is not the virus. So the T cells will get exhausted and they are unable to kill this virus because it is 10,000 times more than this. So when you are doing testing DNA, you are testing DNA. So whenever you are testing DNA, it is one DNA and one hepatitis B surface antigen. When you are testing HBsAg, you will have one DNA virus and pure HBsAg without DNA many times more. So which is a better marker? Surface antigen is a better marker than DNA. Let's go one time more into this. Here, for making DNA, you need a CCC DNA, covalently closed circular DNA, RNA, DNA, double-stranded and out. Here, CCC DNA gives you surface antigen. Now, what is a marker of surface and what is a marker of the virus in the nucleus? Surface antigen, not this DNA. So if you have high HBsAg, you have high CCC DNA in the patient's blood. So now suppose somebody gets hepatitis B by blood transfusion or a needle stick injury. What will happen? It will have an acute hepatitis. The virus goes into hepatocytes, multiplies, but same time T cells come, SGPT or ALT goes above 400, and this patient has acute hepatitis. He will recover. 1% may die. But if the immunity is weak, then this virus becomes persistent. What does that mean? You will have normal ALT. SGPT remains normal if the immunity is very weak. So DNA levels keep on going up and down. ALT will go up and down every 4 months. Whenever there is a high ALT, let's say ALT is high, DNA is down. ALT is high, DNA is down. So high ALT means more cell death. More cell death, less virus. So will you have in acute hepatitis any DNA? Very little. In chronic, you will have very high DNA levels. When the transmission is from mother to baby, it is generally chronic. In adults, 95% is acute, 5% is chronic. So this diagram I showed you last time also. When you get from mother to the baby transmission, DNA is high. Why? It is chronic. So high DNA, high surface antigen, but ALT is normal. ALT levels are normal. This is immune tolerant phase, and this generally occurs up to 15 to 20 years or so. Now, as the time passes, the body becomes immune active. Immune active means there will be high ALT. If the ALT is high, DNA will start falling. And after some time, maybe 30, 35 years or so, the patient's DNA may go down, surface antigen may go down. These patients may develop cirrhosis or liver cancer. I'll not go into details, but this is the natural history of mother-baby transmission. And in India, today, 90%, 95% hepatitis B is mother-baby. In the previous lecture last week, I told you how to write diagnosis of chronic hepatitis B. So, if you have a person who has infection and it is chronic, means more than 6 months, we call it incidentally detected asymptomatic HBsAg positive subject. IDAHs. We don't call the term carrier. I don't have time to tell you, but all carriers also suffer from some liver disease. We also have to differentiate acute hepatitis B, very low DNA, compared to reactivation where the DNA levels are very high. Remember this. How do you write chronic hepatitis B? First is transmission. Has it come from mother to the baby, perinatal, or horizontal by blood, needle stick? The virus can be wild type, E positive. What does E positive mean? Let's go back. E positive means a person has core antigen, means it is a replicating virus. This virus is replicating and it is being released as E antigen. So, E antigen positive is a wild type replicative virus. E negative is a mutant virus. I don't have time, but remember E minus is a mutant virus. Then we have to know the DNA level. Then, as I told you, quantitative HbSAg levels. This is about the virus. Then you have to write about whether liver injury is going, ALT or SGPT. Is it high? Means if it is high, DNA is low. If it is normal, DNA is high. So in immune tolerant, you will have normal ALT and high DNA. Then you have to assess fibrosis, whether by biopsy or by fibroscan, liver stiffness. If it is 8 or more, it needs treatment. Now we go to treatment of hepatitis B. What is the basis and whom to treat? Should we treat all? So one more time, the difference. This is a very important slide for hepatitis B. Acute infection versus chronic. So somebody got blood transfusion or needle stick injury. So in this, hepatitis B is present in the hepatocytes, nucleus, cytoplasm. In these patients, the CD8 positive T cells will come. They will give interferon and they will kill the cell, clean. So CD8 CTLs will come and clean. So now you have no virus in acute hepatitis. These are CD8 hepatitis B specific cells. Now in chronic infection, the virus is present, but the CD8 CTLs are not there. Instead, you have CD4 cells or T regulatory cells, Tregs. They inhibit the immunity. So you have CD4, NK cells, all other cells, but not CD8. They are exhausted. How are they exhausted? Because there was a lot of surface antigen. You remember this slide again? There was so much of 9,900 particles compared to 1. So all HbSAg positive without DNA, the shell alone causes exhaustion and there are no CD8s available. So how do I treat my patient? If I make these cells active, CD8 cells are again active and chronic infections becomes acute, I will cure my patient. So the whole theory of treating hepatitis B is to convert chronic into acute hepatitis B. So virus is cleared when immunity is high. How do you know immunity is high? ALT is high. Higher the SGPT, oh, it is 200. Very good. Higher the ALT, lower is the DNA, as in acute hepatitis. So convert chronic to acute hepatitis B. So what are our goals of therapy? Our goal is virus DNA should disappear. Surface antigen becomes undetectable. Anti-HBs antibody to surface antigen should form. CCC DNA from the nucleus must go away. There should be negligible risk of liver cancer, reactivation, or death. This, however, is not easy. But what you can do is to get the virus undetectable, HBsAg undetectable. So absolute or clinical or functional cure is possible. You may not be able to remove cccDNA. You may not be able to form anti-HBs. So remember, our goals of therapy is also loss of HBsAg, not only DNA. Now these are your two drugs, class of drugs. One class is your nucleoside or nucleotide analogs. These are chain terminators. They don't allow virus from RNA, single-stranded to single-stranded DNA cannot form. They put their amino acids. So what are the drugs? Tenofovir, TAF, or entecavir. This is a lifelong therapy. Once you start, normally 30 to 40 years you have to give. They are very strong antivirals, but very poor immunomodulator. Interferon is a strong immunomodulator. It makes your CD8 active and not very strong viral suppressor. Normally you give 48 weeks of therapy. In this, it is lifelong therapy. Interferon makes your CD8 and also breaks down cccDNA. What is the basis of treatment? Viremia, how much is the DNA? How good is your immunity? And how much is your fibrosis or advanced disease? So there can be a normal ALT, immune tolerant, or cirrhosis or acute hepatitis reactivation. Now we are assessing a patient. The patient has come to you. What will you do? You will do a fibroscan, 8 or more. He needs treatment, or a liver biopsy. And if the patient is already on treatment by some other physician, you have to calculate whether he will develop HCC. There are several calculators. I may not be able to tell you that. You can look into the net. So if you are on tenofovir, TAF, or entecavir, these are first line. Once you start them, you have to monitor the patient's SGPT or ALT every 3 months. E antigen or anti-E maybe 3 to 6 months. And DNA 3 to 6 months in the beginning and then every 6 months. What is the end point? I told you, first E antigen, seroconversion, and then DNA undetectable. If you cannot achieve HBsAg loss, maintain undetectable DNA. Interferon is the most appropriate first-line treatment. Who is a good candidate? Where immunity is good and ALT is above 80. Normal ALT never give interferon. 48 weeks, and generally genotype A is better, not D. A is better. So this is our guideline. Chronic hepatitis B with a wild type E antigen positive patient. Now this person has 20,000 or more international units and his ALT is high, 80 or above. Treat him, no questions. He has high DNA and which drug will you give high DNA? Not really interferon. Now you can give interferon because ALT is high. Sorry, you can treat this guy with interferon. Here, the patient has got 2 times upper limit of normal of ALT. You can monitor, but if he is above 35, treat him. If the DNA level is less than 2000, very low levels, and he has normal ALT, in that patient, you will monitor. However, any category, if the fibrosis is 2 or more, liver stiffness is above 8, you have to treat. So remember, anybody with high DNA and high ALT treat, anybody with fibrosis you will treat. So what are the 3 things? DNA, inflammation, and fibrosis. The question will remain a person with normal ALT here, but DNA is high. Suppose he has a normal ALT, but his DNA is 20,000 or more. What will you do? And he has no fibrosis. He can transmit. These are outliers beyond the guidelines. Such patients today are followed, but we may need to treat them in future. When you are giving drugs like tenofovir, you have to monitor the serum creatinine for kidney function and bone profile every 12 months. Sorry, it is not every 3 months, it is every 12 months. Patients may have muscle symptoms or weakness. If the patient has got decompensated cirrhosis, means he has hepatitis B and cirrhosis and has ascites or has jaundice or has bled, don't worry about DNA or ALT, treat. If he is cirrhosis, then at least he should have more than 2000 DNA and treat. Don't worry about ALT. If he has reactivation, means the DNA levels are high, ALT levels are high, treat immediately. So by and large, chronic liver disease has to be treated by antivirals. Now, can you stop these drugs anytime? So these are new developments. A E antigen positive, we do not know when to stop. Generally, we will not stop in these patients unless he becomes E negative and antibody has formed. So this group continues lifelong. Now, E antigen negative is a group where you can withdraw after HbSAg loss. However, nowadays many people can do after 3 years of E antigen negative and DNA negative, you can withdraw. Interferons you continue to give. However, if the HbSAg level does not come down by 24 weeks, you can stop it. A person in whom you stop treatment, will he have a relapse? Yes. 80%? Yes. Except if you are lucky, your patient has very low HbSAg or has received 3 years or more of treatment. In the beginning had low DNA and had no mutations like E minus mutations. This guy can easily, you can stop therapy. Now, risk of liver cancer on therapy. So, risk factors for development of liver cancer can be virus related or non-virus related. So, virus related factors can be genotype C. Fortunately, in India, we don't have. This is a very important message. If you are treating a hepatitis B patient and his SGPT does not come down to normal, persistently high, even if he has DNA undetectable, this guy can develop liver cancer. Except, yes, if he is obese or drinking alcohol or others. If it is due to hepatitis B, he can develop high risk, 4 times high risk. If the DNA does not come down on therapy, he can develop liver cancer. He is E antigen positive, replicative, 7 times higher. If he has mutations, these are in the basal core of the virus, 10 times. And if the person has developed cirrhosis, he has a very high chance of liver cancer. What are the host-related things? If the person is taking statins, he is protected. Aspirin, protected. Metformin, somewhat protected. If he is on thiazolidinone, he is protected. But if he is on insulin, he has a higher risk of. So you have a hepatitis B, diabetic patient, sulfonylureas and insulin can cause more liver cancers. These are my last few slides on hepatitis B. So you may have new drugs coming. One is, as I told you, bile salt receptor is the receptor which allows hepatitis B to come inside. So you are having new drugs on entry inhibitors. There can be new drugs which inhibit the covalently closed circular DNA. Many new drugs are coming. then the RNA which is formed in the nucleus, when it comes out, you can have an RNA interference. You can also have several drugs. Current drugs are all here, pre-genomic RNA. But current drugs can also prevent RNA to DNA conversion. The current drugs are RNA to DNA conversion. You can also have drugs which may not allow single strand to become double strand or allow virus to be secreted. You may have inhibitors of assembly. All these E antigen, core antigen, surface antigen, polymerase, all of them have to assemble. You can have assembly inhibitors, or you may have inhibitors of surface antigen release, or you may have immune modulators to kill. So all these are drugs in the pipeline. You may start seeing them from 2024. I am now briefly touching hepatitis delta. It is not a common problem, but just to tell you, hepatitis delta is an RNA virus. Hepatitis B is a DNA virus. Delta works like a parasite on hepatitis B. In the world, there are about 30 to 60 million people with delta. There is no vaccine. Remember, if there is no hepatitis B, there is no delta. Delta is only using the nucleus of hepatitis B for multiplication. How do you diagnose hepatitis delta? So HBsAg has to be positive. Now this is co-infection. Both delta and hepatitis B come with blood transfusion. So you will have hepatitis B, IgM, you will have delta antigen, delta RNA, and late onset you will have anti-delta total. So simple form, a co-infection means both viruses have come by blood. You will have surface antigen and you will have delta antigen and delta RNA. Suppose somebody was having already hepatitis B. On that, a needle stick or blood of acute delta has come. In this patient, you will have delta RNA, delta antigen. You will have probably no IgM of anticore, but may have rarely. And this patient will be rapidly increasing in IgM delta. So to simply superinfection, IgM anticore may be negative. While in chronic infection, you will have both of them positive. IgM core may be generally negative. You will have delta, you will have RNA, HBsAg. So how do you differentiate these two conditions? A IgM anticore negative. I will skip these in the interest of time. These are the algorithms. You have a surface antigen positive. If you have a suspicion, then you can do an anti-delta. If it is a superinfection or something, you will do an HDV RNA. You will manage hepatitis B. If after treating hepatitis B, ALT remains high, you may have to assess for hepatitis delta. How do you treat hepatitis delta? Our current drugs, tenofovir and entecavir, TAF, are not active. Only drug active is PEG interferon. So whenever you have a co-infection or a superinfection or a chronic delta, treat by PEG interferon. Treatment is for 12 months. After 6 months, RNA should be generally decreased, and 24 weeks after therapy means at 72 weeks, HDV RNA should remain negative. ALT should normalize. And the best method of preventing delta is to give hepatitis B vaccination to the whole population. If the population is vaccinated, no hepatitis B, no delta. My last two slides. How many of you are immunized against hepatitis B? I can't see you all. but I hope you can answer it. Are you immunized? Then raise your hands. Okay, so Pooja, what is your anti-HBs? Can you send a chat message? What is your anti-HBs? 7, 8 people have raised hand. Please all send me your anti-HBs. Can I see the chat? All have said yes, yes. But what is the anti-HBs? Not done. Okay, so I stop the chat here. So vaccination is not equivalent to immunization. You are vaccinated, but that is not you are immunized. For immunization, you must know your anti-HBs. Your anti-HBs must be above 10, preferably above 100. So if you, let's say, take COVID vaccine, but you don't have your antibody, you will not know. Everybody after COVID vaccine gets the antibody, but not after hepatitis B. Isn't it funny? So you are vaccinated, but you may not be immunized, and therefore get your anti-HBs. And physicians are team leaders. You must have above 100 anti-HBs because in doctors, nurses, 7% do not have antibody formation. With this, I'll stop here now.